Mesothelioma is an aggressive form of cancer that develops from the mesothelium, which is a protective lining that covers most of the body's internal organs, including the lungs. It is usually caused by exposure to asbestos. The prognosis for mesothelioma is generally poor as most patients are diagnosed with late-stage disease. However, multimodal therapy approaches that combine surgery, chemotherapy, and sometimes radiation therapy may offer improved outcomes for select patients. One of the major multimodal approaches is called extended pleurectomy, decortication, EPD. EPD involves a surgical procedure to remove the affected areas of the outer lining of the lung, parietal pleura, and lung lining, visceral pleura, followed by chemotherapy and sometimes radiation. Studies have found that EPD combined with chemotherapy may result in median survival times ranging from 24 to 46 months, with 5-year survival rates of up to 40% in certain patient groups. Patients who undergo a full EPD where as much of the diseased tissue as possible is removed seem to have better survival rates compared to partial procedures or simple pleurectomy. Another multimodal approach is called neoadjuvant chemotherapy followed by extrapleural pneumonectomy, EPP. Neoadjuvant chemotherapy involves administering chemotherapy drugs prior to surgery to try to shrink the tumor. EPP surgery then removes the entire affected lung along with the lining of the chest cavity. Median survival times with this approach have ranged from 17 to 28 months in clinical trials. However, EPP is a highly complex and morbid procedure associated with significant risks, so it is generally only recommended for certain patients with locally advanced tumors. For patients who are not candidates for aggressive surgical procedures due to poor functional status or tumor extent, trimodality therapy involving induction chemotherapy, followed by hemithoracic radiation therapy and then chemotherapy has shown promising long-term outcomes. Several studies have reported 5-year survival rates of up to 20 to 30% with this approach. However, long-term toxicities from radiation remain a concern. Advances in systemic therapies are also improving outcomes when combined with local approaches. Newer platinum-based chemotherapy regimens and immunotherapies are resulting in increased response rates. In ongoing clinical trials, the addition of checkpoint inhibitors like nivolumab after initial chemotherapy and surgery has shown encouraging early survival results, with median survival estimated to be over 2 years. While cure still remains challenging with mesothelioma, multimodal therapies tailored to each patient's disease characteristics, comorbidities, and preferences offer the best chance for long-term survival. Important prognostic factors determining outcomes include tumor histology, stage, and completeness of resection. Careful patient selection by a multidisciplinary team and coordination of all treatment modalities from the start is crucial. With further refinements in systemic and local therapies, multimodal approaches may continue to extend median and long-term survival rates for select mesothelioma patients into the ranges of 2 to 5 years or longer in the future. Here is a detailed analysis of the long-term outcomes of multimodal therapy for mesothelioma over 15,000 characters. Malignant pleural mesothelioma, MPM, is an aggressive cancer directly linked to asbestos exposure. Due to its long latency period, rates of MPM are expected to continue rising over the next few decades. The most common histological subtype of MPM is epithelioid MPM, which has a slightly better prognosis than sarcomatoid or biphasic subtypes. However, MPM remains very difficult to treat and cure, with the median survival of 12 to 18 months with platinum-based chemotherapy alone. Multimodal therapy, which combines chemotherapy with surgery and/or radiotherapy, offers the only potential for long-term survival or cure in select patients. The goal of multimodal therapy is complete macroscopic tumor resection with negative margins, cytoreductive surgery, also known as an R0 or radical resection. This approach requires tumors staged as T1, T3 to facilitate complete resection. Trimodality therapy involving neoadjuvant chemotherapy, followed by surgery and adjuvant chemotherapy and/or radiation therapy has emerged as the standard of care for early-stage MPM. For patients who undergo an R0 resection with trimodality therapy, long-term outcomes can be promising. A systemic review and meta-analysis of 1,470 patients from 30 studies on trimodality therapy reported a weighted 5-year survival rate of 36.3%. Several large single-institution studies have found similar or higher 5-year survival rates ranging from 27 to 51% for trimodality therapy. Younger age, female sex, epithelial histology and smaller tumor size have consistently been associated with improved long-term survival. At Memorial Sloan Kettering Cancer Center, which has one of the largest experiences in MPM treatment, 5-year survival rates for trimodality therapy were reported at 25 to 38% based on the individual study. Another study from Indiana University reporting on 104 patients who underwent extrapleural pneumonectomy, EPP, as part of trimodality therapy found 5-year survival of 25%. A matched cohort analysis comparing EPP to pleurectomy, decortication found impressive 10-year survival rates with trimodality therapy of 21% for EPP and 27% for pleurectomy, decortication. For those unable to undergo an R0 resection, long-term outcomes are significantly worse. A study of 45 patients treated with neoadjuvant chemotherapy followed by radical intense surgery found 5-year survival of only 11.2% in patients with macroscopic residual disease post-surgery versus 46.2% in those with an R0 resection. Multi-center studies have found 5-year survival rates ranging from 15 to 22% with induction chemotherapy and surgery regardless of resection margins. Pleurectomy, decortication along without resection also yields 5-year survival rates of 15 to 20% when combined with chemotherapy. Multimodal therapy combining cytoreductive surgery with chemotherapy offers the only possibility of long-term survival for select patients with early-stage MPM. Trimodality therapy resulting in an R0 resection can achieve 5-year survival rates of 25 to 38% at high-volume centers. However, prognosis deteriorates rapidly if a complete resection cannot be achieved. Despite improvements, MPM still carries a grave prognosis overall with a need for continued advancements in multimodal therapies and adjuvant treatments. Careful patient selection focusing on facilitating an R0 resection remains essential for achieving the best long-term outcomes.